Good morning, everyone. Thank you, Dr. Anju, for the introduction. In the next 10 minutes, I'll be dealing with the evaluation of ptosis. So, ptosis or blepharoptosis, as all of you know, it is the drooping of the eyelids. The 2 points I need to stress is that the head should be in the upright position and the gaze should be in the primary gaze. So, why do we need to evaluate a case of ptosis? It is only a sign, it is never a diagnosis. So, for ptosis evaluation, meticulous history taking is important. Examination and measurements are also required. So, in the history, first and the foremost is the age of onset, if it's a congenital one or an acquired one. The mode of onset, if it's an acute or a chronic. Acute needs more, it's more of an emergency. Always see if there is any history of trauma or any surgery, ocular allergy or recurrent swelling, because all these factors causes levator weakness. Now take a brief history if there is something corresponds to the myasthenia. So if there is any diurnal variability, history of diplopia, dysphagia, weakness of the proximal muscles, all this suggest ocular as well as systemic myasthenia involvement. Always take a family history if there is anyone with positive family history, because in some cases like BPU and CPO and BPS, it's inherited. And old photographs, always ask for the old photographs, because the patient may sometimes notice it very later, but often it's seen that many times it is present even before. In examination, see if there is any facial asymmetry for the frontalis overaction, or if there is any abnormal head posture, which is often a chin lift, especially in children. Now coming to the measurements of ptosis. First and the foremost is the palpebral fissure height. I need to stress two important points. That is, the patient should be looking straight and in the primary gaze. So palpebral fissure height, it is the measurement from the lower lid to the center point of the upper lid through the corneal reflex. And it is divided into two: marginal reflex distance 1 and MRD2. So MRD1, it's a distance from the center of the pupil to the upper lid, and it normally corresponds to around 4 to 5 millimeters. And I would like to say that the normal lid position, it's always 2 millimeters below the cornea. So here is ptosis of the left eye. Now coming to the severity. Mild ptosis is defined as difference of 2 millimeters between the two eyes. If it is 3 to 4, it's a case of moderate ptosis, and if it's more than 4, it's a severe ptosis. Now moving to the levator function test. So how do we do that? Always ask the patient to look down to the maximum and look up to the maximum. So the excursion of the levator, excursion of the how much the lid excurs, this is the levator function test. The measurement of the same is the levator function test. The very important points is that you always negate the frontalis. This is how we grade it. Less than 4 is poor, 5 to 11 fair, 12 to 14 is good, 15 to 18 is normal, and more than 18 is excellent. So importance of lid position on down gaze. This is the first picture. When the patient looks down, you can see that the right eyelid is at a higher position. So it's a case of congenital ptosis, because the muscle is unable to, due to its fibrosis, muscle is unable to relax properly, and it's a case of congenital ptosis. But in the second case, you can see that there is both ptosis, both eye ptosis is there, and left more than right. And when the patient looks down, left position, lid position is lower than that of the right eye. So it's an aponeurotic ptosis because of the stretch of the levator. Lid crease, you can see that in the first case, the baby has, the child, he has no lid crease in the left eye. So this is congenital ptosis. And in the second case, you can see that it has receded. This is a case of aponeurotic ptosis. Now Bell's phenomenon. how do we check the Bell's phenomenon? Ask the patient to forcefully close the lid and look for the excursion of the cornea. If it's less than 1/3 of the cornea, it's good. 1/3 to half the cornea, it's fair, and more than half of the cornea is visible, it's poor Bell's phenomenon. So why do we do this? This is to assess the risk of exposure keratopathy post-surgery. So you can counsel the patient accordingly. Now, the importance of extraocular movements is that this case, as an 80-year-old female, came with sudden onset of ptosis. On lifting up, there is the classic down and out position of the eye, restriction of adduction, elevation, and depression. It's a case of third nerve palsy. Other cases wherein ptosis and UM restriction are there. There is monocular deficiency, elevation deficiency, myasthenia gravis, then CPEO, or some cases of orbital masses, which causes multiple cranial nerve involvement. So this is a child. You can watch the position of the lid. Ptotic eye is opening up with the movement of the jaw. So this is a case of Marcus Gunn jaw winking phenomenon. It's a synkinetic ptosis due to the abnormal connection between the abdominal innervation of the lateral pterygoid. So in a case of Marcus Gunn jaw winking, always ask the parents what is their concern, if it is more the ptosis or if it's the jaw winking phenomenon. And you can counsel the patient accordingly. You can plan ahead based on that. Importance of pupil is that this is a case of mild ptosis with miotic pupil. It's Horner syndrome. And in third nerve palsy, in which the pupil is involved, it's a very surgical emergency, as all of us know. So myasthenia, how do we test for myasthenia? It's the most important test is the ICE test, which has got a very high specificity, around 90% of sensitivity. Here the ICE is kept over the eye for around 2 minutes, and you can see that after 2 minutes there is an improvement in the ptosis. It's a positive one. Now Cogan's twitch, how do we do that? Ask a patient to look down and then around 30 seconds and look straight and look for any upshoot of the upper lid. And fatigability, not that specific, but still ask a patient to look up for 30 seconds and look for the fatigueness of the upper lid. Now, Herring's-Low. So this was a CPO patient. She had her left eye surgery being done, frontal eye sling was done, and a bit undercorrected. And you can see that there is an increase in the ptosis in the right eye. She was counseled prior because she had ptosis, and so this is due to negotiation of the action of the frontalis in the other due to the Herring's-Low. So always counsel the patient accordingly. Always check the corneal sensation and dry eyes so that you can counsel the patient chances of exposure keratopathy. So not always all the drooping which appear as cases which appear as drooping of the eyelids, it's a ptosis. Some can be pseudotosis. Always be aware of the pseudotosis cases. So here the patient had come with small complaints of smallness of her right eye, but you can see that it is actually a case of lid retraction in the left eye. This is another case. Again, she had come with telling that it is a smaller eye in the right, but it's actually brotosis with dermatochalasis. This child, you can see that on cover test, what happened on covering the right test, the upper, left eye is taking its position. So always do a cover test and make sure that it's never a case of hypertropia. And this this person, he had come with a mild ptosis in the left eye. And on inversion of the upper lid, you can see that it's a salmon patch and it's a case of lymphoma. And this, it appears to be ptosis, but this is actually on her on fitting with the prosthetic eye. So it's a case of post-enucleation socket syndrome. So with this, I conclude this is why the ptosis evaluation is very important. Thank you.
Thank you, Dr. Indu, for that elaborate evaluation on cases.